A very good evening, a very warm evening to everybody. First of all, let me thank the organizers for planning this conference, in national level conference in one of the state and one of the prestigious institute, which is All India Institute of Medical Sciences, Bathinda, Punjab. And I'm standing here to tell you all and maybe to motivate you all, since I have been passionate about telling that undertaking research work is as important as academics and as the clinical work, besides your other family, personal, social responsibilities. So the day we start thinking that research is also as important as academics and patient care is, probably then we can make ourselves at a little bit higher ranking, national ranking as well as at a global ranking. So I think if we start seeing our country from a lens of measuring that where do we stand today, as far as our health research ranking is concerned, or our health indicators ranking is concerned, or how far we have moved in achieving our universal health coverage, the sustainable development goals, the various measurable indicators with which we measure ourselves, or we measure most of the countries and we place them in different ranking, first rank, second rank, third rank. And I'm sure that we do, as a country, we have done lot many advancements. And first advancement what really can come to my mind is that we have definitely increased the standard of our medical education in this country by having these premier institutions, which we call as Institute of National Importance, which is All India Institute of Medical Sciences, AIIMS, and that's very great achievement of our country. And I hope that there will be many more such institutions. But still, despite of having this number of institutions, we are we have to run fast. We don't have to walk. We have to really run if we have to, even if compare and reach at the standards of the All Indian Medical Science Delhi, the JIPMER, the Indian Institute of Science Bangalore, our CMC Vellore, our PGI. These are the health institutions, but there are other science institutions also with which we really have to compare ourselves, and we really need to not walk, we really have to run fast. And that running will come if all of you who are attending the session online, offline, at least I'll say that the 50% of those who are listening to me get motivated to really change the path of their career as making research as their very important career. Now, introducing a bit about myself, I am an alumni from Rohtak Medical College, Haryana, MD University. I did my MD in community medicine from PGI, Chandigarh, and thereby I worked for some time in some of the government medical colleges in Himachal and AIIMS, Delhi for some time, less time. Then I joined ICMR in 2006, January 2006. And since then, I'm here for last 18 years. It's around going to be a 2 decade of my career, my whole life, academic and professional career in ICMR. And everybody now knows what is Indian Council of Medical Research is. So Indian Council of Medical Research is an apex body in the country and the oldest body in the world who has been instrumental in promoting the health research agenda. And in 18 years, I have seen various achievements, various landmark initiatives which have been taken to promote the research and to train to build the capacity of the country and to carve out the agenda of the research for this country, and we had been working very closely with the sister department, which is Department of Health and Family Welfare. So I have been now heading the division. We have a division at ICMR, which is extramural division, and one division is the implementation science division. So keeping portfolio of mine experience and my qualification and interest, I have been there as a heading the division of implementation science. But before I move to implementation research initiatives and programs at ICMR, I will take around 10 to 12 minutes. Pardon me if they are a little longer, but they are important for all of you to know that the quality of the research work, research proposals which are submitted to ICMR for funding is optimally very, 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 very low. When I say very low, it really gives a pain to me. Then what are we doing here? We as an ICMR, what is my role? So this is some of these, when I come to such conferences, and I think I have promised to myself that wherever I go, at least I tell that why research is to be carried out and how it should be carried out and what are the common pitfalls which all of you should be knowing. And I'm sure all of you, those who are sitting on the forefront apart from my ICMR colleague, must have definitely tried seeking support from Indian Council of Medical Research, be it would have been a failure, be it would have been a success, or be it would have been in the process. So, I mean, the status of research in our India is not that appropriate, that accurate, that optimally quality-wise, which we should be having in a country where we have around 700 or odd number of medical institutions and other allied institutions as well. So the common thing which all of you should note that we do fund the research. We get large volume of research projects in our ICMR, but majority of the projects, majority of the proposals are rejected because of the poor methodology. They're rejected because of the poor methodology. They may have a good optimum idea, novel idea, they want to do it, and most of the experts, they say idea is good, intention is good, but how will he carry out, how will she carry out is not appropriately mentioned into the protocol. So when I say there is a project from your side and I am there to take it before the expert committee and I have to be defending your side, ki sir, this is written here. If it is not written, I cannot defend your proposal. So the commonest pitfall we have is the very, very poor methodology section which is not appropriately written in the protocol. When I say methodology, it has to be as detailed as possible. You have to put up the study design, study setting, sample size estimation, and probably you can mention the flow charts of the whole method, what you are going to talk about. If it is a house selection, how you are going to enter into the house. If it is a hospital setting, how you are going to select the first patient. If there are 10,000 patients annually coming to your hospital, your sample size is 500, how you are going to select those 500. So all those nitty-gritties are absolutely missing into the proposal. That is one thing. And the secondly, most of the projects, they do not mention the data analysis plan. So whole idea of mentioning the research protocol is various sections which have to be interlinked, interconnected with each other. So in 80% of the proposals, majority, they do not mention what are the data analysis plan. How will they collect the data? How they will quality check control the data, what are the variables, whether independent variable or dependent variables, what will be the analysis plan you will be mentioning, and if you add on the dummy tables into the methodology section, that will be definitely help you out. Another common thing which is not along with the protocol is the patient information sheets. In short-term studentship form, I don't know who are the MBBS students sitting here, and we don't get much STS application from this institution also. We do get from other institution, and they're really performing well. It's a very small grant which we give to the students to encourage, because experts have advised to encourage students to do the research. So that is how we came up with a scheme of short-term studentship. So when in the STS, there is a whole, you have to put up the sheet, the consent form, the patient information sheet, the confidentiality agreement, all those things have to be mentioned. But in ad hoc or in our extramural grant proposals, we do not get all these information attached to the format. So there are many things which we can talk about it, that there is lack of the sufficient information, there is no ethics angle which has been to be mentioned, then objectives are not syncing with the title. So lot many things are there, but I think if you all are serious about submitting the research proposal, so you have to take care of your all those missing links when you write a proposal. Now coming to my topic, which is the implementation research program in ICMR. So before I go to implementation real design, so anybody who wants to plan undertaking this implementation research, now what implementation research is, you need to understand the models. Now, what this model is, this is one framework, this is one model. Now, implementation research is unlikely than the surveys, than the surveillance, than the description, than the epidemiological studies. If any of you have undertaken some course or something about research methodology or a basic epidemiology, you will know that there are various kinds of epidemiology, like we have the cross-sectional and all those designs will come up. But what is different in implementation research is that you have a intervention, you already have an intervention. For example, when you say that if I want administer intravenous dextrose or intravenous iron supplementation, it is going to reduce the anemia burden in our country. So what is the intervention? The intervention is IV use of this iron. Okay. Now this is a proven intervention, and this proven intervention has been undertaken in any of the medical school, any of the setting. Researchers have discovered it. But now whether this intervention will be applicable to all the settings, will be applicable to district also, will be applicable to the hospital also, will be applicable to the community also, or that science taking that intervention to a larger setting, apply to that intervention, we call it as an implementation. So there is a difference between implementation of the project and implementation research project. Okay. So implementation research, if you broadly see, there are 5 boxes. So in those 5 boxes, the box with the red boundary is having an outer setting. Now, when we say that, okay, make these anti-tuberculosis drugs available, it is working, DOT strategy is working, but before it starts working, we need to have, these are all the influencers. On the left hand side, all the boxes are those factors which influence the intervention. So we have the political support, whether the local chief minister of the community of the area wants his population to be given the drug, there is a political commitment, there are certain policies, there are various policies. For example, you want to say the neonatal hypothermia screening program, so that policy has to be there. So these are the settings on which we say that any intervention to be implemented into a larger setting is influenced by the outer setting, and this outer setting is very broad. Political commitment, policies have to be in place, and there have to be the adequate resources also. When we say that, okay, you have the NICSHA scheme for the tuberculosis patients, there is a political will. Okay, and we have the nutrition intervention program for the TB patient, there was a political will. So that is how the program was implemented. Now another setting on the blue boundary is we have the inner setting. Now this inner setting is those who will be providing the services, those who would be, main implementers of that intervention, they also have to be convinced enough, yes, if it is to be done by ASHA workers, to the medical officers, to the CHOs, to the district program managers, they also need to be understanding, yes, this is the intervention, we are also convinced, we are also ready to get this intervention implemented in my district, in my state, in my subcenter. Another box is characteristics of the individuals. These are again an influencer. If we have to put up a contraception to a family, to a community, to a beneficiary, those characteristics, whether they are ready to take up those interventions or not. So that is called as a characteristic of those interventions. So on the left hand side, these are the three outer broad frameworks which affect the implementation research. Now on the right hand side, you have the intervention characteristics with the yellow outline. What does this characteristic means? That intervention has to be cost effective, intervention has to be acceptable, intervention has to make it effective, it has to make a change. And then the last green box, this is where we have that what is the process of implementation. Here it is implementation research. So if there is a research plan to be done for implementation science, you have to have the outer setting, you have to have the inner setting, you have to have the characteristics of the individual, put the intervention in place, and then say that, okay, I am the implementer, I am going to measure it is working or not working. So if it is not working, I have to do the iteration of that intervention so that it works in Bathinda or it doesn't work in another neighboring district, how it will work in neighboring district. That is the role of the implementers or the implementer researchers. Now, when we talk about broadly that I'm speaking about the implementation delivery research, so other three categories of the research with ICMR, we have the three other domains, that's descriptive, discovery, and development. Now, this is, I take it kind of, it should not be affecting you. Should I submit the project on descriptive division, discovery division, or development? So, whatever is your idea, it is us to see whether it fits into any of the four domains or not. But this is just for your knowledge that we have the 4 Ds and they may last longer and they may not last longer, but the only idea is that whatever you write as a research project, you should be able to write it as appropriate, as good as possible. This is something I just wanted to tell that as for your knowledge or those who want to apply to the ICMR funding, these are the four categories. These are the four categories. On starting from left hand to the right hand side, we have the small grant, an intermediate grant, and Center for Advanced Research and National Health Research priority programs. In that subsequent order, what is difference between the small grant and the Center for Advanced Research is the credentials of the investigator, the credentials of the team. If the team is so strong enough, if the team is good, if they have a past track record of having good research, they are capable to get the Center for Advanced Research. And what does the Center for Advanced Research is? They need to have a holistic view and given to the country. Will they train the country? Will they train the, on any of the, lab parameters, on any of the environmental parameters or the climate factors and all? Whatever topic you think of, they broadly support addressing a major health problems, and we have the Center for Advanced Research on antimicrobial resistance, we have the Center for Advanced Research on neonatal mortality, we have the Center for Advanced Research in taking newer medication for tuberculosis also, and same is intermediate grant. These are all the financial ceilings. For intermediate grant, we have the ceiling of up to 8 crores, and for small grant, we have the ceilings up to 2 crores. But all these 4 categories of the research projects which ICMR plans to give it to investigators depends upon only the scientific merit of the proposal. It's only the merit of the proposal. We review it and we give the grant. Now, So this I have already spoken that we need to have, so if we want to have an implementation research project, we should have addressing what are the systems challenges. These are some of the issues: access to healthcare, we don't have appropriate implementation of the national health programs, inequity, quality of healthcare, lack of human resources, and non-participatory intervention. So these are some of the issues which you can take it as a priority topics from health systems angle, and you can fit into any of the condition you want to say, whether it is a CVD control program or a mental health control program or a vector disease control program. In all these programs, we will have these 6 challenges. How you overcome these challenges and barriers could be your one of the research topics to talk about. Yeah, so this is, this I have already spoken to you that intervention has to be effective. But when we say that intervention has to be effective, it hardly matters that with what study design you have been, making these interventions effective. So somebody say that in implementation research project, we need to have a qualitative and quantitative study designs, but it is both. It can be both designs. Even in the implementation research, we take the systematic reviews, meta-analysis as again approach to address that research question. We can take the randomized control trial also. Today only in the meeting there were few projects on randomized control trial, and they were debating upon that why it is an implementation research. I said why not? Because they have taken the community as a broad unit of testing as a control and another community as an experimental or intervention arm. So we can have, if not blinding, but at least we can have the randomized control trial. So study designs have to be appropriately chosen even if for the implementation science. But remember the formula for implementation research, you have to have a proven, effective, workable, upscalable intervention in hand so that you can work upon it. So this is a cycle when you start planning, writing an implementation research project. So you have to start from number 1, what is the context? What is my area problem? Go and discuss with your chief medical officer, go and discuss with your district planner. So yesterday some of the experts and one of the researcher had come to me. He wanted to undertake a study in the state of Madhya Pradesh. I said, you go and ask the Secretary Health Services what is his problem. Because if it is an implementation science, any health systems project, you need to talk to the health officials, what is their problem. We as academician, we as a researcher are the facilitators to improve the health conditions. We just advise them how to go about it. We cannot, just take the topics of our interest. So definitely you have to have a stakeholders engagement, you have to have the framework. As I tell, CIFAR is one framework, RE-AIM is another framework, and this intervention has to be adapted and with the fidelity. So these are some of the do's and don'ts which I'm very fond of, because I really tell very precisely what you should not be doing and what is the deficiencies in an implementation science research projects. I will not go one by one, and I take the right hand box with the last 2 bullets. You see that limited or absence of the stakeholder. We get the project from AIIMS Bathinda, but there is no stakeholder engagement. We want to solve the national program for anemia prevention, but the district program officer of anemia is not on board with us. We want to prevent, we want to encourage the mental health services, but the district program manager for mental health is not on board with this. So those are some of the issues, and then lack of very clear strategies. So you must go through all these do's and don'ts. I'll leave the slide with the organizers, but please go through them very carefully, and one by one word has been written with all of my experiences while reviewing the project at ICMR. I'll just take one example, and this is one project which we have initiated as a National Health Research Priority Project. A National Health Research Priority Project is undertaken by ICMR, where we call an expression of interest for them to participate, and we shortlisted. For this project, we received around 100 applications, and based upon their merit, we selected only 4 sites, because we do not want to compromise the quality of the research as well. Now, what is that intervention for this project? We have trying to improve the coverage of the non-communicable disease services, improve the quality of the services, and equity of the ambulatory care services. We all know, and I don't know how much of you have been well oriented toward the health care services of your neighboring district, but this is really an issue. We do not have adequate manpower, we don't have quality services, we don't have, I always give an example sometimes, the person who is dying of diabetic ketoacidosis is being managed at a sub-center level, and the person who needs just simple medication for diabetes comes to AIIMS Bathinda. So that is something which is very, very, not a good situation for us to handle. So we should be having an equity of the ambulatory care services. So this is one project which we have started from ICMR, and these are the 4 sites which have been selected. And last week I was in Agartala, where the Chief Minister of the Tripura, he himself came and inaugurated this project, and he has given all the support that I will make appropriate referrals, I will make the medications for non-communicable diseases, I will establish the referrals and the linkages, and same we are doing it in Chittor, Nagpur and district Faridabad of Haryana. And on left hand side you see the 8 set of interventions, and all these interventions are doable, workable. Our doctors do not have the standard protocols. We will give them the standard protocols, and ICMR has already developed the standard treatment protocols. Dr. Vitull is aware about it, and I will not talk much about these STWs because that's not my topic here today. Of course, these are available on the website. Strengthening of the governance mechanism. We have the secretary, we have the chief minister, we have the program officers, all political will is there. Probably, I think we are able to tackle the NCD, and they have said that after reproductive and child health, NCD is my priority, CM said, so they are going to address. Patient empowerment, again important intervention. If we don't empower the patient, we are going to lose these patients. Strengthening referral, team building, supportive supervision, and effective use of health information technology. We are using the mobile for all nonsense purposes, but not for strengthening our, the patient care. So this is another project which I will not go in much detail. Again, a national health priority project. It really gives a very shameful figure across the global agenda when our neonatal mortality is in double digit. In one of the state, kids, neonates are dying even if born normally, and neonatal mortality is around 21. In some of the states it is 7. And why should we allow the babies to die when they have been born normally to a normal mother? So there is something which is definitely painful and shameful to us. So we started this project on neonatal mortality again as a national project, and here are the set of interventions which we are planning, and the whole cascade of care from the antenatal services to the postpartum and to the small and newborn babies we are trying to address. And this is for this project, just to tell all of you that the international agency Bill and Melinda Gates Foundation also has joined hands with the ICMR to address these issues of this. So this is another project of implementation which is ongoing. So I think I'm about to end of my talk here, leaving with the message that whenever you apply to the Indian Council of Medical Research, these are some of the priority topics, and they are dynamic, they are variable, they keep on adding and deleting some of the topics into it. And if you do not find any of the area compatible or included into this list, there is always a scope of adding the others. And my personal experience, we hardly see when we review the project whether it falls into the priority list or not. Review the project as per their scientific merit. I don't know, I have been forcefully asked to stop. The mic has stopped working. So I will not go in more detail. I really wanted to say all, but yes, in the last slide, of course, start with a very proven intervention, collaborate for success, adapt to the local context, because cancer is a problem in Punjab, so you should have addressing those issues. So this is all about intervention, but one last message I would definitely like to give you, that I have been asked that, you are the person who has been going to various states in the country, you encourage so many researchers. So my, again, message to all of you would be that at least from the audience, the next call is going to be open in the month of December 2024. Must get some projects from Goa, I went to Goa, now I'm in Bathinda. So probably I get some good research projects, and I see from AIIMS Bathinda probably I like to do justice. So thank you so much for patience hearing, and apologies to organizers for overtaking the time. Thank you so much.
Madam, your mic was not switched off because we dare not do that. ICMR is a premier research organization of the country, and we are really honored that you and Dr. Ravinder are here. So it is a great honor for Bathinda. People think or they don't think as far as the AIIMS is concerned, but we are really honored. And when I met you at Solan, after that I am following ICMR site, and you have beautiful flow charts and guidelines which are really beneficial. And we have sent the message after meeting you to all the, in my group, that you must visit ICMR site, go for the guidelines, take out the printout of any disease, and it is so concise and evidence-based for public health. It is a great thing. So having you here, next time also we will organize it somewhere else with larger audience, and still I must assure you that your lecture will be shared to thousands of people once we get it and put it on YouTube. Thank you very much for honoring us with your presence. Thank you.
Thank you, Dr. Vitull. And just two more messages I want to use this platform.
Please.
Number one, you rightly mentioned the standard treatment workflow. May I request everyone to please open their mobile phones and type into their Google, either the Play Store or the App Store, just type the word standard treatment workflows. You will get 157 standard treatment workflows of 25 specialities. We have made these workflows one pager. Actually, I was supposed to give the talk on one pager document, but topic was this. So you will see that depression has, infertility has, epistaxis has, hypertension has, diabetes has, and this is very useful for all the doctors, and this is the right platform, number one. Number two, that we are conducting the webinars. And we have done 4 webinars, and these webinars are available on the YouTube. There's a whole playlist, and the first induction webinar was done by Dr. Rajiv Bahal, and I did the second one. Subsequently, these 4 webinars have been done. Please download all the webinars. Next webinar will come up on 9th of October. Do listen these webinars very carefully. Of course, there is 1 hour of each duration. You are going to be immensely benefited by all the experts who have spoken about these webinars. So thank you so much for again telling, sir.